So the case that we just discussed was a case of patient that came back from a holiday somewhere, and he has contracted pneumonia that was caused by Legionella pneumophila that will usually respond to erythromycin, ciprofloxacin, and also tetracyclines. Okay. And the next case is a 48-year-old woman who presents to the emergency department with one week history of non-productive cough and increasing breathlessness. So she reports her breathing is much worse than exertion. So the history itself is again pointing to the fact that she's probably having pneumonia. So the next case is a 65-year-old man, okay, was admitted from home with a community-acquired pneumonia. So this is an elderly man, 65-year-old. Okay, he has a history of skin rash to penicillin documented in his medical notes, and he has adverse prognostic features and a CURB score of 4. So this is just a score that we use to grade pneumonia. So the CURB score is the score that we use to assess the severity of pneumonia. So C, when you look at C with its remember confusion. Okay, so look at confusion and then presence or absence of confusion. Then we have so this is usually done by looking at the abbreviated mental test, okay, which is a test that is for preclinical students. You don't have to worry about this, okay, but for clinical students you might want to read further on this. So C is for confusion, then U is for the urea level of more than 7 millimoles per liter, and then R is respiratory rate more than 30 per minute, and then B is for the blood pressure of less than 90 systolic and or 60 millimeters mercury diastolic. And also it's actually CURB 65. So if the patient is 65 or above, then that's also a score. So for a score of 0 to 1, then the treatment is you can possibly discharge the patient from the emergency department or from the clinic setting so that they can get home treatment. Or if the score is 2, then hospital therapy, and if it's more than 3, it indicates severe pneumonia, as in this case. So it's a score of more than 3, so that's a severe kind of pneumonia. So you can't just discharge the patient and ask the patient to come back another day. No, you have to admit the patient for therapy. So basically, the question is, what would be an appropriate empirical antibiotic choice? Okay. So is it just enough to give augmentin, which is amoxicillin clavulanate, and erythromycin? You give augmentin plus clarithromycin for this gentleman, or you need to give augmentin and gentamicin, or you give cefotaxime and erythromycin, or you need to give him ciprofloxacin and metronidazole to cover anaerobes, or you can just give him quinolone, fluoroquinolone, ciprofloxacin plus erythromycin. which one would be an appropriate combination. So this is the explanation for the case. Community-acquired pneumonia is most commonly caused by strep pneumoniae. Okay, most commonly caused by strep pneumoniae, hence the use of a beta-lactam antibiotic. Because of the increased incidence of atypical organisms such as mycoplasma. So, community-acquired pneumonia is the most commonly caused by strep pneumoniae. So we use a beta-lactam antibiotic. So we have to choose a beta-lactam among these choices. So which one is a beta-lactam? Okay. And because of the increased incidence of atypical organisms, okay, so there is nowadays a lot of atypical organisms looking around, such as mycoplasma, then a macrolide such as erythromycin is also recommended. Okay, and augmentin is contraindicated as it is penicillin based. Okay, so augmentin is amoxicillin clavulanate. So and we know that this patient has history of skin rash to penicillin. So he has a sensitivity, he has an allergic reaction to penicillin. So therefore giving augmentin is contraindicated. Okay, so you don't give augmentin. And we have mentioned that we would like to give beta-lactam and also a macrolide. Macrolide is the cover for atypical organisms such as mycoplasma. And ciprofloxacin has poor cover against strep pneumoniae, and metronidazole is used for anaerobic infections. So we wouldn't take ciprofloxacin. It's not useful here. And also metronidazole is not needed here because we're not trying to cover for an anaerobe. So we are not thinking of an anaerobe here, so we don't give metronidazole and we don't give ciprofloxacin. So the answer for this one is C. The most appropriate therapy is cefotaxime and erythromycin. So in this case, and a credible alternative for beta-lactam sensitivity is not mentioned, and the best choice, because of clinical necessity, since severe pneumonia can be fatal if treated with antibiotics that are not effective, is to go with the only cephalosporin and macrolide combination that is offered. Okay, so you don't so students are taking the respiratory module for your first year, so you don't have to worry about this. I don't have to worry about the details, but the fundamental concepts, of course, you still have to understand. So you have to know about that strep pneumoniae is a common cause of community-acquired pneumonia. So you would not only focus on the pharmacological aspects of using a beta-lactam antibiotic, penicillin, or cephalosporin to treat this condition, but you would also want to know and look back at your microbiology lectures and study what is the shape of a strep pneumoniae. Okay, how does it look like? Is it gram positive or is it gram negative? So these are very useful for you to go back to and revise. So you have to be familiar with what is augmentin, which is amoxicillin clavulanate. But for your level, of course, you don't have to know augmentin. You just have to know amoxicillin clavulanate. But once you start working, of course, you will keep hearing this word again and again, augmentin. Of course, you have to know about erythromycin, you have to know about gentamicin, these cephalosporins. second and third generations, and also you have to know about erythromycin. Together with clarithromycin, you have to know about this. The macrolides, and then you have to know metronidazole, which is the antibiotic that is responsible to kill anaerobes. Okay, if you problems remembering this, then you might want to go back to the lecture that I've given previously a few months ago on antibiotics in general, and then you might also want to have a look at what's ciprofloxacin, which is a fluoroquinolone. So the next case is a 32-year-old patient that presents to the emergency department of a local hospital. She's complaining of increasing breathlessness on exertion over the last few weeks. She also reports dry cough and occasional night sweats. And take note that she's under the care of the infectious disease team for HIV and is also 28 weeks pregnant. So examination reveals that she is hypoxic with her oxygen saturations falling still when she is asked to walk. And an chest X-ray demonstrated bilateral infiltrates. So what is the most appropriate antibiotic treatment for this patient given the likely diagnosis? A. Amphotericin, clindamycin, gentamicin, rifampicin, ethambutol, isoniazid, pyrazinamide, and then trimethoprim sulfamethoxazole. So what is the best choice? Obviously this question is a bit it's of a higher level, so probably not for undergraduates, but then it's still useful for you to give you some idea as to how a patient would come to you and present to you once you start working. So in this case, the explanation is, okay, although pneumocystis pneumonia is officially a fungal infection, it does not respond to antifungal medications. So in this case, we are thinking about pneumocystis, which is pointed out by the fact that the patient has HIV, and so the whole clinical picture points out to the patient having a pneumocystis carinii pneumonia. So a pneumonia that is caused by pneumocystis carinii. So it does not respond to pneumocystis. Carinii pneumonia does not respond to antifungal medications. And then trimethoprim sulfamethoxazole has been shown to be as effective as intravenous pentamidine and more effective than other alternative treatment regimens. So the preclinical students, you don't have to worry about pentamidine. So TNP, SMX, trimethoprim sulfamethoxazole is the preferred initial therapy during pregnancy according to the consensus guidelines. And for the treatment of infections that are resistant to TNP, SMX, the combination of clindamycin and primocin is likely to be more effective than intravenous pentamidine. Okay, just forget about this. Okay. So once you find that it's resistant, then only you might want to go to clindamycin and primaquine. Okay. And rifampicin, ethambutol, isoniazid, pyrazinamide are the first-line drugs to treat tuberculosis. Okay, this is undergraduate level. You have to know this. Combination of rifampicin, ethambutol, isoniazid, pyrazinamide are the first lines to treat TB. Although this woman is at risk from TB infection, the clinical history is more in keeping with the diagnosis of PCP, okay, pneumocystis carinii infection, even though it seems to look like or mimic TB infection. So the answer is trimethoprim sulfamethoxazole. Okay, thank you.